heart. Beta 2, beta 2, smooth muscles. কোথাকার স্মুথ মাসেলস? ভেসেলসে থাকতে পারে, ট্র্যাকিওব্রঙ্কিয়াল ট্রি, কোনোটাই সাউন্ড আসছে না। স্মুথ মাসেলস অফ ট্র্যাকিওব্রঙ্কিয়াল ট্রি, স্মুথ মাসেলস অফ ভেসেলস। বিটা 2, আলফা 1 কোথায়? ব্লাড ভেসেলসের স্মুথ মাসেল, অ্যাকশন ইজ vasoconstriction. Beta 2 present in the smooth muscles of blood vessels as well as tracheobronchial, smooth muscles of tracheobronchial tree. Action is relaxation of the smooth muscles, relaxation of the smooth muscles. What is neurotransmitter? What is the adrenergic neurotransmitter? হ্যাঁ, নাম কি? ডোপামিন, ফার্স্টেই ডোপামিন, norepinephrine, epinephrine and dopamine, primarily norepinephrine. চেঞ্জ হচ্ছে না। তারপরটা যাও। Sympathomimetic. What are the different types of sympathomimetics? Direct, indirect and mixed. Direct means they bind with the receptor alpha and beta receptor, bind with them and acts directly. Whereas indirect means they bind with their receptor and release of norepinephrine, and released norepinephrine acts on the smooth muscles. Direct, indirect. What is the difference between the direct and indirect? Directs are directly acting on the alpha and beta receptor and change is conformation and do its action directly after acting the receptor. Whereas in indirect one, they help to release noradrenaline, and that it is not directly act on the receptor. They release the noradrenaline and this noradrenaline binds with the receptor. So there is a phenomena called tachyphylaxis. What is tachyphylaxis? After repeated use of indirect type of sympathomimetic, very rapid loss of response, resistance develop very rapidly. This is called tachyphylaxis, and it is a phenomena of indirect sympathomimetic. Why it is happen? Because after repeated use there is a exertion of this noradrenaline which is present in the nerve ending. So it causes tachyphylaxis. Which one? Indirect type of sympathomimetics. Whereas direct sympathomimetics doesn't cause tachyphylaxis because they directly bind with the receptor and release norepinephrine. Whereas indirect one, they do their action by releasing norepinephrine already stored. So if the stored norepinephrine is exhausted, there will be tachyphylaxis. And there is a third type of sympathomimetics, and it is called mixed type. They can bind with the receptor as well as they can act by releasing norepinephrine. So there are three types of sympathomimetic: direct, indirect and mixed. Among these, tachyphylaxis is the phenomena of indirect type of sympathomimetics. First slide is up. We can classify different adrenergic drugs, but more commonly in case of pharmacological basis it is important. So use of sympathomimetics as well as the classification can come as a single-handed. So first one is pressure agent. Pressure agent means these drugs helps to increase blood pressure. These drugs helps to increase blood pressure. Drugs like noradrenaline or norepinephrine, phenylephrine, ephedrine, dopamine, these are pressure agent. Pressure agent means they helps to increase blood pressure. In which situation it is required to increase blood pressure? Hypotension. shock. So in case of shock, it required. Now there are two. There increase in blood pressure by alpha action. Alpha action means by activating the alpha 1 present in the peripheral blood vessels, and that is increase in systolic or diastolic? Systolic. Then increase in heart by increasing cardiac output by stimulating the beta 1 receptor. So beta 1 action is by increasing cardiac output, there is a increased blood pressure, whereas by increasing or stimulating the alpha receptor, there is a constriction of the peripheral vessels that can also help to increase blood pressure. So the increased blood pressure or pressure effect is by two receptor, alpha 1 and beta 1. So is there any receptor which can cause vasodilatation or fall of BP? Beta 2 receptor, very good. So beta 2 receptor is stimulated by noradrenaline or adrenaline? Noradrenaline. Adrenaline. কি করে? Adrenaline দিল. So adrenaline has a beta 2 effect. Noradrenaline doesn't have a beta 2 effect. So in case of shock, we preferred noradrenaline over adrenaline. In case of shock, we preferred noradrenaline. Which type of shock? If there is a septic shock, we prefer noradrenaline. Why? Because it has alpha 1 action as well as beta 1 action, and it doesn't have a beta 2 action. Adrenaline has alpha 1 action, beta 1 action as well as beta 2 action. So beta 2 action of adrenaline can vasodilate, especially in a very low dose. In very low dose, there is a vasodilatation due to adrenaline, due to stimulation of the beta 2 receptor. Clear? In case of septic shock, why we preferred noradrenaline over adrenaline? Why? Because it doesn't have a vasodilatory effect through the beta 2 receptor. So we preferred noradrenaline over adrenaline. Now dopamine. Dopamine, how it acts? Dopamine has a action of alpha, beta as well as dopamine has its receptor, dopamine 1 and dopamine 2. Now in a very low dose, what they do? They stimulate D2 receptor, and where it is present? কোথাকার ভেন? Splanchnic nerve and কিডনিতে blood flow বাড়ে, vasodilate হয়, D2 lowest, there is 3 concentration, lowest concentration, there is a vasodilatation of splanchnic nerve, and so they increase the blood flow in the kidney in the lowest dose. Now the medium dose. In the medium dose, what they do? D for dopamine. Now in the medium dose, what they do? They, along with dopamine receptor, they also stimulate beta 1 receptor. Now beta 1 is present in the heart. So there is an increased contractility and result into increased cardiac output. So there is a vasodilatation and there is an increased cardiac output. So what will happen? They reverse the cardiogenic shock type of symptom. So they increase cardiac output as well as there is an increased blood flow to the organs like kidney. The first thing what happened in the shock? In the shocks, in a shock state, what is the first hemodynamical change? First thing is that they preserve the blood flow in the major organ like brain, heart, and they try to divert a less perfusion to the kidney. So if there is a less perfusion to the kidney, what happens? If it is prolonged, there will be renal failure. So to counteract that, if we give dopamine, in this situation, there will be first, in the lowest dose, there is a vasodilatation of splanchnic nerve and there is a increased blood flow in the kidney. Next, medium dose, there is a vasodilatation effect plus beta 1 effect. There will be increased cardiac output. So there is an increased cardiac output, there will be vasodilatation. So there will be increased blood flow to the kidney. Now in the highest concentration, what will happen? They stimulate alpha 1 receptor also. Now alpha 1 present in the smooth muscle of the peripheral vessels. So they increase, if there is an increased tone, what happened? The afterload, preload, they also again increase. So it has a bad effect on the shock. So we have to give the dopamine in shock in medium dose, where they can stimulate dopamine receptor along with the beta 1 receptor, but not stimulate the alpha 1 receptor. Clear? To explain why we prefer noradrenaline over adrenaline in septic shock. Now why we are preferred dopamine in case of septic and cardiogenic shock. Clear? To explain why. Next one is cardiac stimulant. Now these are the cardiac, if now the problem is in the heart, that means either there is a less generation of the impulse. So there may be sinus bradycardia, there may be AV nodal delay. In this situation, we preferred adrenaline. Over the other drug. Other than the adrenaline, dobutamine. Dobutamine is a congener of dopamine. It is a very close, chemically close, but the difference is that they doesn't have a action on the dopamine receptor. They act through the beta 1 receptors. They primary cardioselective drug. That means they stimulate the beta 1 receptor and used in cardiogenic shock. So in cardiogenic shock, drugs used preferably dobutamine, adrenaline, and there is another drug is isoprenaline. What are the receptor that stimulated by this isoprenaline? Isoprenaline acts on which receptor? All beta, no alpha action. So adrenaline has beta 2 action, then noradrenaline doesn't have beta 2 action, and isoprenaline doesn't have any alpha action. You have to remember it. Clear? So isoprenaline, where it used? It used as a temporary measure in heart block. Suppose a patient come in your emergency with a heart rate of 40, but maintaining blood pressure. You can wait for suppose 2 hours or 4 hours for a temporary pacemaker. Now in between this time, we can use isoprenaline. Clear? Dobutamine used in cardiogenic shock, adrenaline used in cardiogenic shock, whereas in case of bradycardia with maintained blood pressure, we can use isoprenaline. Isoprenaline has beta 1, beta 2, beta 3 effect, but no alpha effects. Now bronchodilators. Bronchodilators like salbutamol, tarbutaline, in fact isoprenaline also previously used, they has a action on beta 2, and now beta 2 present in smooth muscles of tracheobronchial tree. They also present in smooth muscle of vessels. That in that situation, the smooth muscles of beta 2, when it stimulate, it vasodilates. Similarly, beta 2 present in the smooth muscle of tracheobronchial tree, when it stimulates, it bronchodilates. So beta 2 receptor agonists like Isoprenaline, salbutamol, tarbutalin, all these, they stimulate the beta 2 receptor. Beta 2 receptor. Clear? তাহলে beta 2 present in the কোথায় স্মুথ মাসেল অফ ট্র্যাকিওব্রঙ্কিয়ালটিতেও ইউজ হয়, আর কোথায় আছে ভেসেলসেও আছে। ভেসেলসের যে বিটা 2 সেটা লো ডোজ অ্যাড্রিনালিন স্টিমুলেট করে, আর বিটা 2 which is present in the tracheobronchial smooth muscle, they are stimulated by isoprenaline as well as tarbutalin, salbutamol, all these drugs used in which condition? Bronchial asthma as well as chronic obstructive pulmonary disease, COPD. Clear? In these two conditions, these drugs used to stimulate, so beta 2 agonist or antagonist, this is the MCQ, this will be the MCQ, beta 2 agonist or antagonist? Huh? In asthma we used remember that it is beta 2 agonist which is used in bronchial asthma and COPD. Beta 2 agonist, not the beta 2 antagonist. Now পরেরটা যাও না। Another beta 2 use is uterine relaxant. Uterine relaxant means if there is premature contraction during labor, huh? Tocolytic agent, very good. Tocolytic agent, beta 2 agonist, they stimulate the beta 2 receptor present in the smooth muscle of myometrium, uterine smooth muscle. তাহলে তিনটে স্মুথ মাসেলে বিটা 2 থাকে কি কি? একটা ভেসেলস, হ্যাঁ একটা ভেসেলসে, সেখানে কি তার ক্লিনিক্যাল সিগনিফিকেন্স কি? বিটা 2 প্রেজেন্ট ইন দ্য ব্লাড ভেসেলস, vasodilation by adrenaline in low dose. Now next one is beta 2 present in the smooth muscle of tracheobronchial tree, stimulated by salbutamol, tarbutalin, used in clinical situations like bronchial asthma and COPD. They relax the smooth muscle of tracheobronchial tree and has a beta 2 effect. Now the third smooth muscle relaxation is as a tocolytic agent. Ritodrine is commonly used as a uterine relaxant when it is used if there is a premature contraction. In that case, to relax the smooth muscle of uterus, we used beta 2 stimulant. But all these beta 2 stimulants or agonists are different, because you cannot use salbutamol in case of premature contraction or ritodrine for the inhalation purpose, because it designed like that, and there is a change of the route of administration so that they select different beta 2 present in different organs. So adrenaline relax the vascular smooth muscle in low dose, whereas tarbutalin, salbutamol commonly used as a inhaler, as a local agent in case of bronchial asthma, COPD. Ritodrine used as a tablet in case of early premature contraction. This is the use of beta 2 agonist in clinical settings. Now nasal decongestant. Nasal decongestant means if there is a cough and cold, what happen? The mucosa in the nasopharynx and oropharynx, they are inflamed. The mucosa is inflamed. The vessels inside it or around it, the capillary primarily, venules, they became, if there is a inflammation, what happened? They became leaky. There is a porous. So they vasodilate, and there is a transudate comes out with them. And what happened? These edema, they form the edema in the mucosa, and that causes the nasal stuffiness. Now the drug that can affect alpha 1 receptor alpha 1 receptor. So what happens if there is a stimulation of alpha 1? Alpha 1 কোথায় প্রেজেন্ট হয়? হ্যাঁ, তারও আগে আলফা 1 কিসে হয়? প্রাইমারি অ্যাকশন কি? হ্যাঁ, কোথায় থাকে আলফা 1 এর ফার্স্ট ডিস্ট্রিবিউশন বলতে গেলে? সবার আগে কি বলতে হয়? স্মুথ মাসেল। কোথাকার? কোথাকার? vessels is smooth muscle. So if there is a stimulation of alpha 1, there is a stimulation contraction of the smooth muscle of blood vessels. So there is a vasoconstriction. So that gap will be reduced. The gap in the blood vessels will be reduced. There is a less leakage of the transudate. So there will be less edema in the mucosa. As there is a less edema in the mucosa, there is a reverse of the nasal stuffiness. Clear? না আরেকবার বলতে হবে। So in case of inflammation, the mucosa present in the nasopharynx and oropharynx, they are inflamed. So what happened? The vessels, which type of vessels present there? Capillary venules, primarily they vasodilates, and there is a transudate. So there will be the edema of the mucosa of oropharynx and nasopharynx. So they causes the nasal stuffiness. The alpha 1 receptor agonists like xylometazoline, oxymetazoline, pseudoephedrine, they stimulate the alpha 1 receptor. As there is a stimulation of alpha 1 receptor, what happen? Alpha 1 receptor stimulate hole vasoconstriction and less amount of the fluid come out from the vessels. So there will be less edema that can counteract the nasal stuffiness. Then CNS stimulant drugs. CNS stimulant drugs like amphetamine, dexamphetamine, they stimulate the hypothalamus and they helpful in case of bolo. And last one is anorectic drugs. They used in obesity. So use of adrenergic drug. What are the different use of adrenergic drug? First one as a pressure agent to counteract the hypotension, especially in shock. Then in cardiogenic shock, what are the drugs used? Are adrenaline. Noradrenaline used in shock. Dopamine used in shock. ঠিক আছে? প্রেসার এজেন্ট, কার্ডিওজেনিক। দেন বিটা 2 স্টিমুলেন্টস। বিটা 2 স্টিমুলেন্টস অ্যাকশন কিসে কিসে আছে? ভেসোডাইলেটেশন একটা, তারপরে হচ্ছে ট্র্যাকিওব্রঙ্কিয়াল ট্রি, ব্রঙ্কিয়াল অ্যাসমা অ্যান্ড সিওপিডি, অ্যান্ড থার্ড ওয়ান ইজ প্রিম্যাচিওর কন্ট্রাকশন অফ লিভার. It is all are beta 2 receptor. They relaxes the smooth muscle contraction. Clear? Last three are nasal decongestant. Nasal decongestant drugs acts on which receptor? Alpha 1. Then CNS stimulant action and anorectic used as a obesity drugs. পরের স্লাইডে যাও তো। Now why we preferred, number one, we already discussed that there is a, why we preferred the noradrenaline over adrenaline. In cardiogenic shock, rise of BP also increase the cardiac work. Why we preferred adrenaline, isoprenaline in case of cardiogenic shock over noradrenaline? Because noradrenaline doesn't have a beta 2 effect. As there is no beta 2 effect, there is a chance of increase high BP. If there is a vasoconstriction, there is a increase preload also, afterload also increase, preload also increase, and that also increase the cardiac activity, and that can lead to dangerous effects. So in case of cardiogenic shock, we prefer dobutamine and dopamine over noradrenaline. Now another explanation why is that why we used adrenaline along with some local anesthetic in case of local anesthesia. Why we used adrenaline along with local anesthetics? Because adrenaline stimulates alpha 1 receptor, and that leads to vasoconstriction. As there is a vasoconstriction, less amount of drug absorbed to have systemic side effect. Number one. So there is a high concentration of drug present in the site, and there is a prolongation of action. Number two, less side effect, prolongation of the duration of the action. And as well as the third point is that as there is a vasoconstriction, there will be less bleeding. Why we preferred or mixed adrenaline along with local anesthetic. Adrenaline along with local anesthetic. Stimulate করবে, vasoconstriction হবে। হ্যাঁ বলো। In case of local anesthesia, the amount of local anesthetic present around the nerve is important. কাকে কি করে ভেসো তো কনস্ট্রিকশন করবে? হ্যাঁ, তুমি তো নার্ভের পাশেই দেবে। লোকাল অ্যানাস্থেসিয়া মানে কি? যে নার্ভটা ব্লক করতে চাইবে তার কাছে পিঠেই তো তুমি লোকালি দেবে অ্যানাস্থেটিকটাকে। সেই লোকাল অ্যানাস্থেটিকের সাথে তুমি যদি অ্যাড্রিনালিন মিশিয়ে দাও তাহলে কি হবে? দেয়ার উইল বি ভেসোকনস্ট্রিকশন। অ্যাজ দেয়ার ইজ এ ভেসোকনস্ট্রিকশন দেয়ার উইল বি নাম্বার ওয়ান, বুঝতে পেরেছো? দেয়ার উইল বি less systemic absorption leads to less side effect, prolongation of the action due to presence of this local anesthetic in the acting site, and third one, there will be less bleeding due to vasoconstriction. In case of epistaxis, we can compress adrenaline 1 in 10,000 locally soaked. Other than adrenaline, phenylephrine and ephedrine 1% can be used for the epistaxis. Action, how it acts? They stimulates the alpha 1 receptor, there will be vasoconstriction, and there will be less bleeding. Nasal decongestant already discussed. How it acts, nasal decongestant, they stimulates the alpha 1 receptor. As there is a stimulation of the alpha 1 receptor, there will be less transudate, so there will be less edema, mucosal edema, less stuffiness. In cardiac arrest, we preferred adrenaline. In case of partial or complete AV block, we used isoprenaline. Isoprenaline acts on which receptor? Beta 1, beta 2, beta 3. There is no alpha receptor. But in case of cardiac arrest, we prefer adrenaline because adrenaline has a beta 1 receptor for stimulus as well as beta 2. So there will be vasodilate. In case of cardiac arrest, if there is a vasodilatation, in less cardiac output, we can manage to supply blood to the peripheral organs. In congestive cardiac failure, what are the drugs we can use? Dobutamine. But drug of choice in congestive cardiac failure, No. It is furosemide. It is a diuretics. It is a drug of choice. Now, drug of choice means it is the first drug to be given. How it acts? They vasodilates the pulmonary congestion vessels. So there is a shifting of blood from the lungs to systemic circulation. So drug of choice is not dobutamine. Drug of choice is furosemide. It is a high ceiling diuretic. But if it is not controlled by furosemide, we can add dobutamine. How dobutamine acts? One receptor? D2. Dopamine D2 te kore, dobutamine beta 1 receptor. Beta 1 receptor. So, in case of congestive cardiac failure, neither noradrenaline nor the noradrenaline, but the dobutamine is the only pressure agent or adrenergic drugs we preferred. But it is not the drug of choice. Drug of choice is furosemide in congestive cardiac failure. Loop diuretics. Bronchial asthma, COPD, already discussed. Beta 2, drugs like isoprenaline, terbutaline, salbutamol, they bind with the beta 2 receptor present in the smooth muscle of tracheobronchial tree, vasodilates, helps in asthma and COPD. Now, in another shock that is called anaphylactic shock. Anaphylactic shock. In anaphylactic shock, drug of choice is adrenaline. Very good. How it acts? Vasodilatation. Where is the problem in anaphylactic shock? Vasodilatation. Anaphylactic shock. In anaphylactic shock bolcho. In anaphylactic shock, there is a mucosal edema in tracheobronchial tree, as well as there is a constriction of the smooth muscle in tracheobronchial tree. Now, adrenaline, in that case, they act to the beta 2 receptor for beta 2 receptor for counteract the contraction in the tracheobronchial tree. Second point, they stimulate the alpha 1, and like nasal congestion, they constrict the vessels in the mucosa of tracheobronchial tree. Anaphylactic shock, there is a constriction in the smooth muscle of tracheobronchial tree, and there is a mucosal edema present in the tracheobronchial tree. So we used adrenaline to relax the beta 2 receptor, to stimulate the beta 2 receptor, to relax the smooth muscle of tracheobronchial tree, as well as through the alpha receptor, alpha 1 receptor, they can constrict the mucosal vessels. So mucosal edema in the tracheobronchial tree will be less. In anaphylaxis, the main problem is the breathing problem. The air passage to the capillary nerve, smooth muscle, bronchial smooth muscle. The dewar pore, adrenaline, interact by the alpha receptor in case of anaphylactic shock. Uterine relaxant, ritodrine, beta 2 receptor, chalo poreta ja. Aro pore ja. Pore. There is some central effects it can use in attention deficit hyperkinetic disorder. It can be used in narcolepsy. In case of Parkinsonism, amphetamine improves the mood, and it can be used in obesity also. These are the central action of the adrenergic drugs. Dopamine, sometimes dopamine, dobutamine come as a short note. So first, dopamine, what are the receptor in which they act? So dopaminergic receptor, alpha 1, beta 1. So in low dose, they vasodilates. In the medium dose, along with the vasodilatation, there is an increased cardiac output. And in the highest this vasodilatation is counteracted by the alpha 1 vasoconstriction. Next, dobutamine. Dobutamine doesn't act on the dopamine receptor, but both alpha and beta. They increase force of contraction in the cardiac muscle, increase cardiac output. Where it is used? Dobutamine primarily contraction বাড়িয়ে cardiac output বাড়াবে. আয়নোট্রপিক, ক্রোনোট্রপিক, ডার্মোট্রপিক, তার মধ্যে আয়নোট্রপিক এফেক্টটা বাড়াবে, ক্রোনোট্রপিকটা কম বাড়াবে বা বাড়াবে না, ক্লিনিক্যালি সিগনিফিকেন্ট নয়। পরেরটাই যাও, এফিড্রিন। মেনলি দে অ্যাক্টস অ্যাজ এ ইনডাইরেক্ট। ইনডাইরেক্ট আর ডাইরেক্টের মধ্যে পার্থক্য কি? ডাইরেক্ট সিম্প্যাথোমাইমেটিক আর ইনডাইরেক্ট সিম্প্যাথোমাইমেটিক। Direct sympathomimetic and indirect sympathomimetics. Konta? Tachyphylaxis. How it acts? They bind with their receptor and they release norepinephrine for their action. Whereas direct one, they binds with the alpha and beta receptor and their action is subsequent. They doesn't require the storage of norepinephrine. So ephedrine is a indirectly acting sympathomimetic. They can, আরেকবার বলবো, direct and indirect. Direct one like adrenaline, noradrenaline, they directly bind with the receptor. Receptor bind করে, then their subsequent action. They doesn't require the release of norepinephrine from the storage. In case of indirect one, they bind their receptor. Their action is depend upon the release of the already stored norepinephrine. Indirect one. So what happened when we used indirect one repeatedly in a short times? There is a exertion of the norepinephrine, stored norepinephrine. So their action will be blunted. That cause this phenomena called tachyphylaxis. Indirect. Amphetamine, it is a synthetic compound. It has a long duration of 4 to 6 hours. It is a potent CNS stimulant and weaker peripheral vasodilator. Maximum selectivity is dextroamphetamine and mephentamine. They increase concentration, they reduce sleep, but after some time, all these things require much more than the normal one. Suppose you take it and you didn't sleep before during the examination time. So last one is, so the amphetamine group of drug, they act as CNS stimulants, and last one is anorectic drugs. Anorectic drugs, they act to the serotonin and norepinephrine, and they reduce the appetite stimulation of the CNS. The side effect of this anti-obesity drug primarily is cardiogenic. Fenfluramine, dexfenfluramine, these are the anti-obesity drugs. Anti-obesity drugs are used to reduce weight, but after 3 months, most of their action became resistant. So even after taking the drug, the obesity is not reduced. Body weight will not reduce. একদম লাস্ট দিকে স্লাইডে বলবো। Anorectic agents, they inhibit the feeding centers in the CNS. But their CNS stimulant activity are very less. There will be no CNS stimulation activity, but depression inhibit the feeding center. They release or reverse transport the noradrenaline or serotonin or dopamine. Reverse transport. Noradrenergic, there may be noradrenergic, serotonergic, and noradrenergic and serotonergic both. Fenfluramine, dexfenfluramine, they are the primarily used, but after for a slide after 3 months the obesity, anti-obesity effect will be less, and there is a obesity যতটা তোমার ফার্স্ট 3 মান্থসে যতটা এফেক্ট হবে তারপরে আর সেরকম কাজ করবে না, ঠিক আছে, বাট দেয়ার ইজ এ ইনক্রিজ চান্সেস অফ toxicity, and toxicity which system affects primarily cardiac activity. Depending upon the in which CNS portion it act. CNS এর different portion এ অ্যাকশনটা ডিফারেন্ট হবে, বুঝতে পেরেছো? হ্যাঁ, এত মেকানিজম না থাকলে এতদিন ধরে কাজ করছে কেন লোকজন, সেটা তুমি ভেবো না, তুমি আমি করছি। ডিফারেন্ট পোর্শন অফ দ্য ব্রেন দে আর সিলেক্টিভলি লাইক দ্যাট। ওকে, দ্য মেন সাইড এফেক্ট মানে ফেলিওর হচ্ছে আফটার 3 মান্থস, অ্যান্ড দেয়ার ইজ এ সিরিয়াস টক্সিসিটি, স্পেশালি কার্ডিয়াক টক্সিসিটি, pulmonary hypertension বাড়ায় in long use. So what is now the treatment of choice for obesity or morbid obesity? Treatment of choice of obesity, এখন তো ড্রাগ খুব একটা প্রেফার করে না, আইদার ডায়েট, এক্সারসাইজ, আর সেটা যদি না হয় ব্যারিয়াট্রিক সার্জারি। নাও হ্যাঁ, শুধু বোটক্স না, আরো অনেক কিছু করে, স্টমাকটাকে নেন। হ্যাঁ বলো, ওবেসিটি প্রাইমারিলি এগুলো অ্যানোরেকটিক ড্রাগ আগে ইউজ হতো, কিন্তু আফটার লং ইউজ, অ্যাটলিস্ট আফটার 3 months দ্য এফেক্টিভনেস উইল রিডিউস, and it has been seen that in random studies there will be much more toxicities there, toxicity like cardiac toxicities and increased pulmonary hypertension, these type of things. So now the primary management of obesity is diet, exercise in mild to moderate, and in case of morbid obesity there is a bariatric surgery. Yeah, তাহলে এখান থেকে কি এক্সপ্লেন হয়, কি আসবে, এক্সপ্লেন হয় এই চ্যাপ্টারগুলো থেকে কি এক্সপ্লেন হয় আসবে। Why adrenaline used with local anesthetic? কেন? হ্যাঁ, prolonged duration of local anesthetics. Number 2, less bleeding, and third one is less systemic effect of the local anesthetic, less toxicity of which drug? Local anesthetic, not adrenaline, local anesthetic. Now how metazoline, oxymetazoline, these drugs are used as a nasal decongestant. Third one is why we prefer dopamine over noradrenaline in case of cardiogenic shock. Why we prefer dobutamine over noradrenaline in case of congestive heart failure. Key use of drug of choice? Drug of choice, furosemide. Furosemide is the drug of choice. Why we prefer noradrenaline in case of septic shock over adrenaline? Why? কেন? beta 2 vasodilatory effect present in case of adrenaline, not for the noradrenaline. ঠিক আছে? আর হচ্ছে different type of clinical use by for the beta 2 agonist. What are the different clinical importance of beta 2 agonist? কি bronchodilators, nasal decongestion beta 2, হ্যাঁ তিনটে স্মুথ মাসেল, bronchodilator, uterine relaxant and vasodilator. ঠিক আছে? আর কি আছে বলো এদিকে? আচ্ছা, শর্ট নোট, অ্যাজ এ শর্ট নোট ডোপামিন, ডোবিউটামিন, এই দুটো অ্যাজ এ শর্ট নোট। শর্ট নোটে কি কি লিখতে হয়? ইন্ট্রোডাকশন অফ আ ড্রাগ, আফটার দ্যাট মেকানিজম অফ অ্যাকশন, তারপরে ফার্মাকোকাইনেটিকে কি কি লিখবে? চারটে হেডিংয়ে। রুট অফ অ্যাডমিনিস্ট্রেশন, তারপরে কিরকম ডিস্ট্রিবিউশন আছে, টি হাফ কীরকম, মেটাবলিজম কোন কি এনজাইম দিয়ে হয়, এলিমিনেশন কোন রুট দিয়ে হয়। এটা কিন্তু শর্ট নোটের মধ্যে ফার্মাকোকাইনেটিক বলছি, ফার্মাকোডাইনামিক হচ্ছে মেকানিজম অফ অ্যাকশন, তারপরে হচ্ছে সাইড এফেক্ট অর অ্যাডভার্স এফেক্ট, আর লাস্ট ওয়ান ইজ ক্লিনিক্যাল ইউজ। শর্ট নোট যদি আসে একটা ড্রাগের এই কটা জিনিস লিখতে হবে। ডোবিটামিন কিভাবে এই ড্রাগগুলো হয়, কি কি দিয়ে হয়, পুরো অ্যাড্রিনালিন নন অ্যাড্রিনালিন, হাউ ইট এলিমিনেটস। হ্যাঁ না, এনি নিউরোট্রান্সমিটার, সাপোজ ইট ইজ এ নিউরোট্রান্সমিটার, হাউ ইট অ্যাক্ট, হাউ দেয়ার অ্যাকশন এন্ডস, এনি নিউরোট্রান্সমিটার, either there is a enzymatic degradation for adrenaline, noradrenaline or adrenergic group of drug, it is COMT or MAO. এটা enzymatic degradation তিন ভাবে হয়। সেকেন্ড ওয়ান ইজ রিঅ্যাপটেক, মানে সাইন্যাপস থেকে রিঅ্যাপটেক করে প্রিসাইন্যাপটিক জায়গায় চলে গেল। আর থার্ড ওয়ান ইজ ডাইলিউটেশন। অল নিউরোট্রান্সমিটার their action is terminated by 3 ways. Number 1 enzymatic degradation, number 2 হচ্ছে reverse transport or reuptake, and third one is dilutional. এবার এর মধ্যে কোন এনজাইমের ক্ষেত্রে কোনটা এনজাইমেটিক ডিগ্রেডেশন বেশি হয়, কোনটার ক্ষেত্রে রিঅ্যাপটেক হয়। ড্রাগগুলো বেশিরভাগই সিওএমটি বা মাও দিয়ে ডিগ্রেডেড হয়।